Good morning. Myself Dr. Srushti Bajaj, resident from MGM Medical College. My topic for today's presentation is role of diagnostic imaging for evaluation of Mullerian anomalies. Embryogenesis, the female reproductive tract develops from a pair of Mullerian duct that forms a fallopian tube, uterus, cervix, and upper two-thirds of vagina by the process of organogenesis, fusion, and septal resorption. Any disruption of Mullerian duct development during embryogenesis can result in broad and complex range of congenital abnormalities, which are called as Mullerian duct anomalies. 15% of women who experience recurrent miscarriages are reported to have Mullerian duct anomalies. These are classified using most common classification system developed by American Society of Reproductive Medicine into 7 categories. Hysterosalpingography, 2D or 3D ultrasound, and MRI are the imaging modalities used for diagnosis of suspected case of Mullerian duct anomalies. The classification of uterine anomalies is divided into 7 classes, which are uterine aplasia or hypoplasia, uniconvert uterus, uterine didelphys, biconvert uterus, septate uterus, arcuate uterus, and DES drug-induced. The aim and objective, the studies aim to evaluate role of diagnostic imaging in various Mullerian anomalies with its prevalence. It also helps to describe the characteristics of Mullerian duct anomalies and their implications for fertility and pregnancy. It was a time-bound observational study carried on for 1 year from September 2022 to September 2023 in the Department of Radiology, MGM Medical College and Hospital, Aurangabad. The cases are included were the female patients with variable clinical indications, including amenorrhea, abdominal pain, and infertility. The one who were the known case of any Mullerian duct anomaly to look for any complications. The exclusion criteria included patients with MRI incompatible devices or implants and patients with claustrophobia. Methodology, there were total 30 patients who underwent the diagnostic imaging. HSG was done in 8 female patients under fluoroscopy guidance presenting with infertility. In few patients, the findings were correlated with 2D or 3D ultrasound findings, and 22 patients underwent the pelvic MRI done on 1.5 Tesla Philips MRI machine. The sequences taken were as follows: T1 weighted image, T2 image, T1 fat sat, diffusion, T2 gradient images, and contrast imaging. The result which was seen in this study, maximum cases were detected between the age of 16 to 30 years, approximately that was 60%, and 1 to 15 years, approximately 26.6% cases were detected, and less number of cases were detected in 31 to 45 years of age. Distribution of result based on HSG and MRI findings. The maximum number of cases seen in my study was uterine hypoplasia, which is approximately 30%, followed by septate uterus, then followed by biconvert uterus, uniconvert uterus, arcuate uterus, and no cases of uterine didelphys or DS drug-induced were seen. Out of 9 cases of uterine hypoplasia, 44% cases were associated with renal anomalies. Discussion: in our study, maximum number of Mullerian duct anomalies were recorded to be uterine hypoplasia or oogenesis, which were predominantly detected on MRI. HSG had no role in detection of this anomaly. It can be isolated anomaly or a part of Mayer-Rokitansky-Kuster-Hauser syndrome, which represents the most extreme form of Mullerian duct anomaly with complete oogenesis of proximal vagina, cervix, and uterus. This was the case of uterine hypoplasia, in which there is a rudimentary uterus with hypoplastic upper 1/3 of the vagina. And in coronal image, we can see that both the ovaries are seen normally. So this was the case of MRKH. The second most common Mullerian duct anomaly in the study was found to be the septate uterus. It occurs when the fibrous septum between the two Mullerian ducts fail to resolve. The septum may be muscular, fibrous, or combination of both. It is important to distinguish a fibrous septum from the muscular septum, as the surgical approach is different for both the cases. This was the coronal MRI image of the septate uterus, in which we can see the fundal contour is normal. This was the HSG done, and it was reported as the subseptate uterus, and this is the 3D ultrasound image of the septate uterus. Approximately 20% patients had the prevalence of biconvert uterus in this study, which is characterized by partial non-fusion of the Mullerian ducts. Can be of 2 types: biconvert uniconvert and biconvert biconvert uterus. This was the HSG image which showed the biconvert uterus. This was the sagittal section of MRI, in which there were 2 uterine horns. One was there was complication in one horn, which was that was obstructed, and this is the normal uterine horn. This obstructed horn is also seen connecting to the cervix. This was the case of biconvert biconvert uterus. Out of 30 patients, 4 patients were diagnosed with the uniconvert uterus, which can be of 4 possible subtypes: absent rudimentary horn, non-cavitatory rudimentary horn, cavitatory communicating rudimentary horn, and cavitatory non-communicating rudimentary horn. This was the actual T2 image. This was a normal uterus which was seen communicating with the cervical canal, and this was a rudimentary horn which was far apart from the normal uterus. And this is the HSG image in which a single horn was seen. The 3 patients also had arcuate configuration of uterus. However, they were compatible with normal pregnancy and delivery. In this study, we found no case of Didelphys uterus and DS drug-induced Mullerian anomaly. Uterine Didelphys results from complete non-fusion of both Mullerian ducts. The individual horns are fully developed and almost normal in size. The uterine abnormalities include hypoplasia and T-shaped uterine cavity in DS drug-induced cases. 44% cases of uterine hypoplasia showed association with renal anomalies like renal agenesis. However, others include multicystic dysplastic kidney, horseshoe kidney, and cross-fused ectopic. There was 1 case of Hurlin-Werner-Wunderlich syndrome which showed the obstructed hemivagina and renal agenesis. To conclude, the Mullerian anomalies may be initially detected at HSG during investigation of infertility or at ultrasound. MR imaging is currently the imaging modality of choice due to its reliability and accuracy. On identification of MDA, radiologists should also look for associated renal and skeletal anomalies. It is essential to accurately classify Mullerian duct anomaly, as surgical planning often varies widely between the Mullerian duct anomaly subtypes, and these are the references. Thank you.
One question. I don't know whether, which is now the latest accept classification in ultrasound for Mullerian anomalies?
It's a European classification.
What is the name?
It's a European classification from U0 to U6.
Yeah, so I think you all should not, when you make your presentations now, you quoted right now American Reproductive Medicine.
Yes.
That's now outdated. So ISHRI classification is now used all over the world. So you need to put it in your next lecture when you make it, because now nobody follows American Reproductive. I wanted to tell all residents yesterday also. Now ISHRI is the gold standard for Mullerian anomalies on ultrasound. And excellent workups, very good.
Yeah, Dr. Srushti, it was a very good presentation indeed. Just one question, you mentioned in your protocol, MRI contrast was used. Any specific indication for contrast in MR?
So when there are obstructed horn or something which we have to differentiate it from the lesions at that time.
Obstructed
Pelvic.
horn, how does contrast help?
So pelvic
Contrast means IV contrast, right?
Yes, sir.
In MR? Okay.
So pelvic lesions could show the contrast enhancement.
Actually, you mean to differentiate the normal anatomical variations from a pathological lesion?
Pathological variation.
Okay. That in those case scenarios, contrast was used, or in all the cases?
No, sir, in those only. In few cases only contrast was used, not in all cases.
Okay, okay. Thank you.
Can you open your presentation? Can you show with marker, you were trying to show that SAG image of the MR, what it is, because I was trying to figure out.
Yes, sir.
I also read little bit of MR.
So these were the 2 horns.
Acha, okay.
This was the obstructed horn, because of which there was a collection in this horn, and this is the normal uterus. And normal uterus was seen continuous with the cervix, and this was the obstructed horn, which here we can see the connection. So this was biconate bicollis.
One more question. How do you differentiate, what criteria were used to differentiate between septate and an arcuate uterus on MR?
So it is difficult to differentiate, but in septate uterus, there is more indentation of the fundus.
Yeah, exactly. That is what I am trying to ask. Any specific definition or measurements? Vertical, horizontal?
Vertical distance should be 1 centimeter less. It
okay.
is awkward.
Yeah, yeah.
One more question. What's the ultrasound criteria?
That is the ultrasound criteria.
No, what's the ultrasound criteria?
The criteria which you mentioned right now was MR or ultrasound?
Ultrasound criteria.
Or there are same criteria?
So this was the ultrasound criteria, MR.
So if it is wide and obtuse, then it is?
It is biconate uterus.
No. Why biconate? I'm talking between arcuate and septate.
Arcuate.
Arcuate is a normal variant now
Yes.
all over the world. So still, when you pick up arcuate and septate, how would you distinguish one from each other on ultrasound?
So in arcuate only, there is only indentation will be seen.
So the angle is?
Angle is obtuse.
That is the only way you differentiate. Good, very nice.
Thank you, sir.